Hey guys, welcome back to my channel, The ENT Resident. Today we'll be talking about decannulation. In my previous classes, I discussed everything you need to know regarding tracheostomy, and today I'll be talking about how to remove the tracheostomy tube, and this process is called as decannulation. You can also now purchase my notes. I have added links in the description. Okay, let's get started. So, what is decannulation? Decannulation is the process by which we remove the tracheostomy tube. And when do we do it? Once the patient no longer requires it for whatever purpose it was taken. Maybe it was done for airway protection or for suction clearance or for prolonged ventilatory support. We spoke about when we were talking about indications of tracheostomy. We discussed how if a patient requires to be intubated for a prolonged period of time to give them ventilatory support, and if this duration exceeds 3 weeks, in that case, we prefer to convert the patient into a tracheostomy rather than keep them intubated. So, decannulation is basically the process of removal of the tracheostomy tube once the patient no longer requires it. This is the final step that we need for weaning off from the tracheostomy. Now, why is decannulation needed? Usually, tracheostomy should not be kept for longer than necessary. Why so? The longer that you use the tracheostomy tube as a way for ventilation, it will lead to certain complications of tracheostomy, which you can again check out my video where I discussed about all the complications of tracheostomy. Now, some of the complications that will happen because of the prolonged usage of the tracheostomy tube is tracheal ulceration. If the tip of the tracheostomy tube is constantly rubbing in the inner wall of the trachea, it can lead to the development of tracheal ulceration. It can lead to increased tracheobronchial secretions, even granuloma formation around the raw areas, and it can even lead to tracheal stenosis and the development of very unsightly scar. So, we should aim to remove the tracheostomy tube not a minute longer than what's necessary. That is why decannulation is required. Now let's talk about what are the scenarios in which act as the indications for decannulation. So our first no-brainer indication is the resolution of the pathology that necessitated the need of tracheostomy. So whatever reason because of which we did tracheostomy for the patient, when that pathology has been resolved. Second is the patient having normal protective laryngeal mechanisms. That means when the patient is able to swallow without any aspiration during swallowing, and the patient has a good cough reflex. So, all of this combines up to normal protective laryngeal mechanism. Third indication is when there is no planned further interventions, like, for example, radiotherapy to the head and neck or any head and neck surgery required, maybe for certain carcinomas. When no planned further interventions are there, that is also an indication for decannulation. And lastly, when there is no longer a need for mechanical ventilation to the patient. So, these are our four indications when we'll know that we have to perform decannulation in our tracheostomized patient. So now you have decided that you want to do decannulation, but what are some certain minimum criteria that you have to meet in order to proceed with this decannulation? So, first of all, consciousness. The patient has to be awake, alert, cooperative, and obeying your commands. Second is we'll have to check for airway patency. There has to be no upper airway obstruction. So the patient should be able to breathe comfortably through their upper airway. And when you deflate the cuff, the patient should be able to tolerate the cuff deflation. Third is cuff and suction clearance. So patient should have a strong cuff reflex. Otherwise, that can lead to aspiration. Second, there should be manageable secretions in the aerial tract, which doesn't require as much of frequent suctioning. So the patient should have a strong cough reflex and manageable secretions. Fourth is swallowing. So the patient needs to have normal swallowing, and when they are swallowing, there should be no aspiration happening. Fifth is oxygen saturation. Now, the patient's oxygen saturation should be maintaining at least above 90%. It should not go below this. And lastly, when you check for ventilation, there is no need for mechanical ventilation, and the partial pressure of CO2 is in normal limits. So, these are some minimum criteria that we need to meet in order to proceed forward with decannulation of a tracheostomized patient. Now, there are certain investigations that you can ideally do as well before decannulation. These include X ray of the neck in an AP view and a lateral view, a chest X ray in PA view, flexible laryngoscopy so as to visualize the airway directly, check for vocal cord mobility, check for any laryngeal edema, granulations, or stenosis. Then do a swallowing assessment. This will help you to evaluate the risk of aspiration in your patient. So you can do fees. Sorry, you can do fees to check for the swallowing assessment. And lastly, in children, we should perform a arterial blood gas analysis to check for CO2 levels. So these are some minimum investigations that you may perform before you go for decannulation. Next, let's talk about what is the procedure for decannulation. So, usually we put a patient on a cuffed tracheostomy tube. If you look at the image over here, this is what the cuffed tracheostomy tube looks like. So, our first chance would be to deflate this cuff. So, once this deflation of the cuff is done, we check whether the patient is able to tolerate the deflated cuff state or not. If they are able to tolerate, we go on forward to perform our next step and we change them to a uncuffed tube. So we remove this cuff. Now we check again whether the patient is able to tolerate this or not. If they are able to tolerate, then we go to a third step, which is blocking the tube. Now, how do we do this? We'll block the tube during the day and we'll keep it unblocked at night for the first 24 hours. So, there's only blocking of the tube during the daytime. If the patient is able to tolerate this, then we move on to our next step where we occlude the tube completely for a full 24 hours. At this point, we check is the patient able to tolerate it or not. If they are not able to tolerate it, then maybe the next step would be to downsize the tube, to go a lower size to allow for more room around it. And if the patient is able to tolerate, then we know that we can remove the tube. So we go ahead and remove the tracheostomy tube. And we place a very airtight dressing to occlude the stoma. Now, this stoma usually it'll depend on the how long it takes to heal will depend on how long the tracheostomy tube has been there for. In most cases, it heals within a time of 2 weeks. Now, how do you do this dressing? We place a lot of gauge square pieces together, and then over it we apply a very occlusive dressing so that there is no air leak happening. And whenever we see that there is an air leak happening, we change the dressing. Most of the times, the wound heals by itself, but sometimes the wound may not heal. In that case, we will require some surgical management where we do secondary suturing in two layers. Patients who have been dependent on tracheostomy tube for a very long time, they may actually require a more prolonged process for decannulation because they may have some anxiety related to it, that they become kind of psychologically dependent on the tube for breathing. So they have some anxiety around it that maybe if the tube is removed, they won't be able to breathe. So decannulation in such patients may require way more time than usual. So, this is our process or the procedure that you need to follow to perform decannulation. Now, there's a term which is known as difficult decannulation. This is a very important Viva question that you are asked, and you'd be asked what are the causes of difficult decannulation. So, first, let's try to understand what do we mean when we say difficult decannulation. This means the failure to tolerate the tube removal or the need for reinsertion of the tube because the patient is landing in respiratory distress, airway obstruction, or other secretion issues. So, the patient is basically not being able to tolerate the removal of the tube, and you need to reinsert the tube. Now, what are the causes of difficult decannulation? Our first cause would be persistence of the condition for which tracheostomy was done. So, in any situation where the condition for which we have done tracheostomy has not resolved, we should definitely not take those patients up for decannulation because they will not be able to tolerate it. Second is the development of obstructive granuloma around the stoma or below it, where the tip of the tracheostomy tube have been impinging. As I mentioned, this is one of those long-term complications of tracheostomy that occurs when a patient has been on a tracheostomy tube for a long time. Third is a case of tracheal stenosis or subglottic stenosis. I had mentioned in a previous class where I was discussing about the different types of tracheostomy that if you do a high tracheostomy, which is done through the first tracheal ring, since it is very close to the cricoid cartilage, it can lead to perichondritis of this cricoid cartilage, leading to subglottic stenosis. So, in these cases, also we'll face with difficult decannulation. Next cause is an incurving of the tracheal wall at the site of the tracheostome. That means at the site where the tracheal incision was given. Next is tracheomalacia, where there is weakening of the walls of the trachea, and the moment you take the tube out, the walls collapse, and the patient ends up in in difficult respiration. Next is tracheal edema, and lastly, I had mentioned before, a lot of patients can have psychological dependence on tracheostomy and the inability to tolerate resistance of the upper airway. So, in these cases, also you'll face with difficult decannulation, and you'll need to be very patient, and it'll take longer than usual cases for decannulation to happen. So, these are our 7 causes of difficult decannulation. Lastly, let's discuss what are some precautions we should take in case of a decannulation in a child. First of all, is we should, in case of a child, you should take the child to the OT and perform the decannulation there so that you have an anesthetist available in case something goes wrong. Second, before you start decannulation, you should have all the equipment required for reintubation available, like a good headlight, a laryngoscope, a proper sized endotracheal tube, and even the tracheostomy tray should be available. And before you perform decannulation, do an endoscopy and check for do an endoscopy of the larynx and check for any laryngeal edema, the movement of the vocal cords, etc. And lastly, after you perform decannulation in the child, you should observe them for several hours and look out for some warning signs like respiratory distress, tachycardia. You maintain the oxygen saturation levels. Sometimes you may even need to do an arterial blood gas analysis to check for partial pressure of oxygen and carbon dioxide in them. So these are some precautions we'll take in case the patient is a child whom we are decannulating. So that's all you need to know about decannulation. If you have any further questions on this, you can note them down in the comment section and I'll get back to you. Thank you.